Hello, my name is Tyler Blashman. I'm a second-year master's student in the Division of Kinesiology and Health, studying under Dr. Evan Johnson. And the topic of my thesis is the potential of exercise to reduce nocturia in older adults, and it is a scoping review. So to start off, we're going to discuss first off what nocturia is. So the International Continence Society defines nocturia as waking during the night to go to the bathroom or to void your bladder, and followed by sleep or the intention to sleep. Nocturia is prevalent in both men and women. So as we can see here, this is from a meta-analysis with the sample size of over 1,000 in each gender group, composed of over 227 studies, and A is males and B are females. And as we see here, as we increase in our age brackets, we see an increase in prevalence of nocturia. We also see a increase in severity of nocturia as well. So nocturia, 50 million Americans have it, 10 million are currently diagnosed with it, and 1.5 million are receiving treatment for it. So why is nocturia a problem? So nocturia has costs associated with it that are estimated between $61 to $62.5 billion annually for United States citizens. So this cost is mainly due to a loss of productivity and then sick leave associated with it. It's also associated with a reduction in quality of life, and then that effect increases with increased severity. So over here we see a questionnaire. So it's an overactive bladder questionnaire, and it measures the quality of life in individuals who have overactive bladder symptoms. So individuals with no nocturia on a scale of 1 to 100 have 92.7, and then we see significant decreases in that with increasing severity of nocturia. It's also associated with diabetes, heart disease, obesity, depression, higher risk of falls, and not surprisingly, all-cause mortality. So over here, this is from another meta-analysis. So these are pooled hazard ratios. So anything above 1 is a greater risk for all-cause mortality in this case. So men and women, on average, if you have nocturia, you're at between 1.32 to 1.38 times more likely to succumb to all-cause mortality. And then with greater than 3 voids, so like severe nocturia, you have 1.6 for our 1.46 for our pooled hazard ratio. So this is kind of a shame because it can be treated in a relatively low and cost-effective way, and we'll get to that later. So to kind of understand nocturia, we want to know what the causes of nocturia are as well. So in short, they are these. So this is, before you start to read this, I want to let me say, don't worry, we're going to break this down and use this kind of as a roadmap to understand the causes of nocturia. So these are our main kind of causes. So we have our 2 large causes here, and we have common comorbidities. Look in the dash lines there. So first off, we're going to start with circadian rhythm disruption. So the first one we're going to look at is AVP, so arginine vasopressin. So we want to start off by addressing what arginine vasopressin is. So it's a hormone commonly called antidiuretic hormone in other places. It's made in the hypothalamus, and it is stored in the posterior pituitary gland. It is stimulated, released by plasma osmolality, or the concentration of your blood. And its main functions here are vasoconstriction and decreasing free water clearance. So the decreasing free water clearance is the one that really kind of gets disrupted with our dysregulation in our circadian rhythms. So normally AVP goes down to the collecting ducts in the renal tubules, where it acts as a protein that helps facilitate the diffusion of water. So it helps reabsorb water across those epithelial membranes. So if you have increased AVP, you're going to be reabsorbing more water and therefore excreting less water. So normally what we see is circadian rhythm, so a release of AVP changes throughout the day. So during the day, daytime hours, there's going to be less AVP, so you're going to have increased urine production. And then at night, you're going to have more AVP, which reduces your urine production. So AVP rises and peaks around 4 a.m., and it can be up to 9 times higher compared to daytime levels. In older patients with nocturia, we don't really see a nocturnal polyuresis, so increased urine production at night. There is no significant rise in AVP at night. So you kind of see this flat line. And this also happens in younger individuals as well. So anuretics, so people who it's commonly called bedwetting. So these children also display a lack in the circadian rhythm. So the controls, the normal controls, are here on the left in the white boxes, and you can see there's a lower level of AVP at night, and then it kind of lower level of AVP during the day, and it spikes at night. And with the anuretics, we don't see that circadian rhythm there. So circadian rhythm, or AVP, also has a role with regulating circadian rhythms itself within the hypothalamus. So if there's a less secretion, so if we're secreting less AVP, it's going to therefore affect the coupling of the central oscillators of circadian rhythm with our peripheral oscillators of circadian rhythm. So that's this arrow up here. And that again just results in decreased aquaporin 2 channel action and decreased water retention, which therefore leads to an increase in nocturia. The second pathway also deals with circadian rhythms, but we're going to be talking about angiotensin 2 because this is another one that is affected by it. So to start off with angiotensin 2, we have to talk about the renin-angiotensin-aldosterone system. So this takes usually a couple lectures in any physiology class, and you could talk about it the whole semester, but we're going to go and just kind of explain this diagram. It's a very good way to just kind of hit the big points. So angiotensinogen is released by your liver constitutively, so constantly, and then when your juxtaglomerular apparatus detects within your kidneys detects a drop in blood pressure, they release renin. Renin then cleaves angiotensinogen into angiotensin 1, and then angiotensin 1 is cleaved by angiotensin converting enzyme found in the lungs and in the liver to angiotensin 2. So angiotensin 2 has a couple different effects, so thirst and drinking, vasoconstriction, and then also it has an effect which we're going to be focusing on the adrenal cortex, where it binds there and then it releases aldosterone, and then aldosterone increases sodium reabsorption and then potassium excretion in the distal tubule of the collecting duct of the nephron. So this is important because if you have higher aldosterone levels, you're going to be increasing reabsorption of salt, and then therefore water, because the osmotic pressure water will follow that salt. So angiotensin and nocturia, similar to AVP, children with nocturnal polyuria, there is no observable circadian rhythm in angiotensin 2, and then also in adults, there's been found that there was no observed, there was an observed decrease in angiotensin 2 at night. So if we have a decrease in angiotensin 2, we have a decrease in aldosterone, and therefore a decrease in reabsorption. So, and then from there, we have an increase in urine production overnight. So that's that pathway. Going to move on, and we're going to talk about COPD and obstructive sleep apnea. And this kind of goes two different pathways. So we have the AVP and angiotensin, AVP and atrionatriuretic peptide, and it also has an effect in the dipping blood pressure as well. So COPD is a chronic inflammatory lung disease that causes obstructed airflow in the lungs, and then the symptoms it's generally caused by long-term smoking or jobs in which you get particulate matter you breathe in particulate matter, and it increases in prevalence as we age because there's a longer exposure to that. So the symptoms, we have difficulty breathing, cough, and then sputum production and wheezing. All right, so COPD and nocturia. So 69.9% of patients with COPD report having to get up and go to the bathroom. There also is noticed that there's an increased ambulatory blood pressure during sleep, and then increased sympathetic nerve response. This is in COPD and in obstructive sleep apnea, where sympathetic nervous response via the alpha-2 adrenoreceptors and the norepinephrine release inhibit the secretion of AVP and also inhibits its action through atrionatriuretic peptide. So it increases the sensitivity of AVP during sleep, and it also decreases AVP secretion during sleep. And then it also has an effect on the non-dipping blood pressure, which we will talk about next. So blood pressure or hypertension is one of those major causes that we identified earlier in the main diagram. So Hypertension has an effect also on on the dysregulation of circadian rhythms, and we'll go through this pathway too. So we have a relative increase in aldosterone during the daytime, so we're reabsorbing more water during the daytime, and then this is caused by, or this is accompanied by a decrease in renin production, a decrease in sodium excretion capability, and then normal aldosterone levels, and then the aldosterone levels increased through a separate pathway caused by hypertension. So the result of this is there's decreased sodium excretion during the day, and so there's this buildup during the day, and you need to get rid of that, and the only time to get rid of that is at night. And then also there's this phenomenon called pressure natriuresis, where higher glomerular filtration pressure is needed to excrete the same amount of sodium when compared to control. So this causes that non-dipping blood pressure, so that's phenotypic in about 15% of patients with hypertension, so a good amount of people within the United States. And then there you see that compensatory increase in excretion of sodium at night, and then that leads to nocturnal polyuria. So this, coupled with the so this is from a meta-analysis. Here we see the urine volume. So it increases between the day and night in patients with nocturia. We also see a decrease in concentration. So we're seeing more water being excreted at night. And also our sodium is a little bit, so it's higher, significantly higher excretion at night. So that's that pathway. The last pathway we're going to talk about is diabetes. So with diabetes, there's an increase in your blood glucose, and with that, your body needs to get rid of that. So there's increased glucosuria. So when you have more solute, the solvent, or the water in this case, is going to follow that because of our osmotic pressure, and that will increase our urine volume. So that's just the summary of kind of all the causes of it. And so the current interventions for nocturia, so we have our loop diuretics, we have beta blockers, anticholinergics, antidiuretics, and then desmopressin. So loop diuretics, they reduce total body water. Beta blockers reduce electrolyte reuptake and increase water excretion. Anticholinergics reduce symptoms of overactive bladder. Antidiuretics, so they reduce the amount of, they're kind of similar to AVP, so they increase or reduce excretion, and then desmopressin, which is an exogenous AVP. So that replaces AVP function. And then there's also lifestyle modifications for nocturia as well. So there's reduction in fluid intake, there's compressive stockings, and more recently there's been pelvic floor muscular training, which focuses on contractions of the musculars of your pelvic floor, and that helps with continence, and it's been shown to be relatively effective, and even more effective than some of the pharmaceutical interventions done by, there's a Johnson research group, not our Dr. Johnson, Theodore Johnson, and he did that back in 2006 and then up to 2016. I believe they're still working on that. So these are so aging has influences on all of these like main core causes of nocturia, but also so does exercise. So exercise has been shown to be a powerful entrainment stimulus for circadian rhythms, so it can help reset our circadian rhythms. It can also reduce obstructive sleep apnea, and then it can work downstream with COPD patients to help with the sensitivity of AVP. And then exercise also has an effect. There's many studies. It's in the ACSM recommendations guidelines book, where it's been shown that exercise can decrease the prevalence of hypertension and sometimes reverse it, and same thing with diabetes. So exercise has effect on all of these, which could therefore reduce nocturia. So only one study has specifically looked at the effect of exercise in nocturia, and it's a fairly casual study. It's done by a Sugaya in Japan back in 2007, and it worked with 30 participants over the age of 71, and they did a 30-minute walking sessions, and they had 8-week intervention for that. As we can see here, most of these are significantly reduced, including nocturia frequency. So instead of people getting up on average 3.3 times per night, they are getting up 1.9 times per night, which is clinically significant because, as we saw from those risk factors earlier, the higher we have, or the more nocturia episodes they have per night, the more likely they are to succumb to all-cause mortality and all of those other associated conditions. And then also here, they used a different quality of life score to where it went from 4.2 to 2.2. And that was a significant reduction in that score, which lower score was a higher quality of life in this case. So now they know that exercise is related to the causes and comorbidities of nocturia, and only one study specifically addresses this. So therefore, the purpose of my thesis is to draw attention to this novel therapy through the writing of a scoping review. And this can help the field because since human research is limited, and this can draw attention to the evidence into draw this evidence into one spot. And we can present this to other researchers and hopefully affect their views on this. So the methods of my thesis, so we're going to be writing a scoping review. So scoping review, the purpose of it is to provide an overview of the available research evidence without producing a summary to a discrete research question. So it's different from a systematic review or a meta-analysis in that way. So we're answering, okay, so it's useful in broad questions and assessing the information before conducting systematic review. That's kind of how it's normally used. So it's a useful approach when the information has not been comprehensively reviewed or is fairly complex, which the causes of nocturia are. So that fits our study fairly well. We have the PRISMA guidelines as well. So they have PRISMA guidelines specifically for scoping review to make this a more systematic process. And then our variables of interest will be the number of voids per night, the frequency of the exercise, intensity of the exercise, duration, and then the type of the exercise, and those their effects on nocturia. So the journal that we want to present to is the Journal of Physiology. So we want to send our manuscript to the Journal of Physiology topical review proposal. So the goal of the topical review proposals are to synthesize current information, to express their own opinion, and then they also look for direct and easy to read paper summaries and diagrams, which much like the one that I made earlier, that will be updating that once we get more information from the literature search itself. So these are also designed for younger professionals just getting into the field. They specifically mentioned like postdocs working with experts in the field, much like yourselves. So the search terms you're going to be using here, and that is my thesis proposal.